Students, so now let us start with the CNS, that is central nervous system. Now in CNS, what all things we'll be completing? So we'll be doing sedatives, hypnotics, then we'll be doing Parkinsonism, drugs which are used in Parkinsonism, drugs which are used in epilepsy, then the neuropsychiatric illnesses like psychosis, depression, mania, anxiety. Then we'll be studying about the opioids and various neurodegenerative diseases, right, like Alzheimer's and multiple sclerosis. And we will be doing the anesthetics, that is the general anesthetics. So all these things we'll be completing in the CNS. Okay, now let's start with the sedatives and hypnotics. Now sedatives and hypnotics. So sedatives are the one which calm, while hypnotics are the one which induce sleep. So understand them very clearly. Sedatives do not cause sleep. They are not used for sleep. Sleep play hypnotics are used. Sedatives are those drugs which calm the patient, right? So now when we see the drugs, the CNS depressant, drugs which are CNS depressant, because to calm the CNS or to calm the or to make the person sleep means that you are actually sedating, you are depressing, you are hyperpolarizing the electrical impulses. Very simple to understand that way. So the CNS depressants, they cause sedation, they cause hypnosis, they cause anesthesia, and then they can even cause coma depending upon the dose, right? So what are the drugs which we study in sedative hypnotics? We study barbiturates, which we'll be writing as barbiturates, BBT. We also study benzodiazepines, which we'll be writing as BZT, and then newer drugs. Newer drugs are there like zopiclone, zolpidem. These are non-benzodiazepine sedatives. Then zaleplon. Then there are some drugs which are also newer receptor, I'll write it here, orexin receptor antagonist. And what is the drug in that? That is called as suvorexant and lemborexant. Then we also have melatonin agonist. So in melatonin agonist, the drug that we have is ramelteon, and another drug that is tacimelteon. Then some other hypnotics, that is chloral hydrate, glutathione, and meprobamate. Okay, so this is the classification of the sedative hypnotics that we'll be completing in this video, and we'll be going forward to other chapters. Now let us understand the mechanism of action. So to understand the mechanism of action, first we need to understand the structure of the GABA benzodiazepine chloride ion channel complex. So what is that? GABA, it is called as GABA benzodiazepine chloride ion channel complex. Now this is basically an ion channel. So say this is the cell, extracellular, intracellular. Now this is actually a pentameric rosette structure. Okay, so it has got 5 leaves structure. I'm showing the what I'll say a 2-dimensional transfer section. So here there is the chloride ion channel, like this it goes. This is the chloride ion channel, and these are the rosette structures which are surrounding the chloride ion channel all along, on all these 4 sides, and so it becomes like a pore. This is a pore through which chloride ion passes. Okay, now it has got A, 2B and 1 delta leaves, and on the A, then this is B, then another, like A is there, B is here, and then here in front they will have another leaf, right, like this. So now the various sites that basically what happens, see, increased chloride ion conductance. पहले तो सबसे basic चीज है कि when the channel opens, then there is an increased chloride ion conductance, and that will reduce the that will cause CNS depression. That will reduce the activity. That will reduce the action. Okay, electrical impulses. Now GABA attaches to this, and the site of GABA attachment is here. Okay, so this is the site of GABA. Now what does GABA do? GABA attaches to this site, and it increases the duration of channel opening. So now this is important because they ask questions on this also. So GABA attaches and increases the duration of channel opening, right? So GABA की site यहाँ पे है, GABA यहाँ पे attach होता है. Okay, now there is a site for barbiturates and there is a site for benzodiazepines, right? Barbiturates, they attach here somewhere in the middle part. So this is the site for barbiturates, right? This is the site where barbiturates are attaching. Now barbiturates, what do? Barbiturates, they bind to another site and they increase the, I'll say they are called as GABA, they have action which is GABA mimetic, and they are also GABA facilitatory. Mimetic means they directly activate the GABA receptor, and facilitatory, they increase the binding of GABA to the GABA receptors. So here they basically, again, barbiturates, I'll say they increase the duration of channel opening, right? So this is the action of barbiturates. Benzodiazepines, now benzodiazepines are different. Benzodiazepines, they attach somewhere here. This is the action site of benzodiazepine. So benzodiazepines, what do? They basically bind to a different site and they increase the binding of GABA. So they are mainly GABA facilitatory. They don't have GABA mimetic, and they increase the frequency of channel opening. Okay, so when barbiturates, they increase the duration of channel opening. Benzodiazepines, they increase the frequency of channel opening. Okay, so we have studied the sites. Now let us see the other agonist and antagonist. Now there is a drug called as bicuculin. Now this bicuculin, it binds to GABA A receptor. Okay, and this acts as a competitive inhibitor or competitive antagonist of GABA, right, and non-competitive antagonist of benzodiazepine. So bicuculin कहाँ attach होगा? Bicuculin भी यहीं पे attach होता है. Bicuculin attaches here. So this is a competitive antagonist of GABA and inhibits the action of GABA. Then there is another drug which is called as beta carbolin. Now beta carbolin is an inverse agonist at benzodiazepine site. So beta carbolin, it is an inverse agonist at the benzodiazepine site. So ये जो benzodiazepine की site है यहाँ पे inverse agonist के रूप में beta carbolin attach होता है and it inhibits the action of benzodiazepines. It increases convulsions. It is a drug which will produce convulsions. Okay, and there is another drug that is flumazenil. This flumazenil is a competitive antagonist at benzodiazepine site, and so it inhibits the action of benzodiazepine and also inhibits beta carbolin. So flumazenil, again, it acts here. So flumazenil is the drug which is a competitive antagonist at benzodiazepine receptor, and it inhibits the action of benzodiazepine as well as beta carbolin. So you can see that this is the GABA A benzodiazepine chloride and channel complex. Opening of chloride channel causes CNS depression. GABA produces its action by directly attaching to its receptor and increases the duration of channel opening. Barbiturates, they are mimetic as well as facilitatory. Benzodiazepine is only facilitatory. And these are the flumazenil, bicuculin and beta carbolin are the antagonists of these drugs. Okay, now let us see them one by one. So let us first see barbiturates. Specific features of barbiturates. Now barbiturates, they basically, we have understood the mechanism. They increase the duration. Barbiturates in clinical practice, they are used very less. Like in epilepsy, phenobarbital may be used, right? And anesthesia, these are the only two uses, that is thiopentone. So apart from these two uses, barbiturates are not used nowadays. Now why not used? Because first thing, they have a very narrow therapeutic index. The safety profile is very low. They're not safe because they have a steep DRC. So a very little increase in the dose is going to increase the depression manifold. Then secondly, they are very powerful enzyme inducers. So they cause a lot of drug interactions, right? Then third thing, they have very high abuse liability. So producing this abuse, they can precipitate withdrawals. Then we don't have no specific antidote for poisoning. Okay, so if somebody takes them by accident, suicidal or homicidal, we don't have any antidote, specific antidote for them. So that is why these drugs are not preferred nowadays, right? What are the adverse effects? Let's see the adverse effects of these drugs. Now, first of all, they cause hangover because they have a very long duration of action, and they also reduce the duration. They distort the sleep architecture. They reduce the duration of REM stage 3 and 4 and increase the duration of stage 2. So they distort the sleep architecture. Then they impair the memory, impair the learning and memory. So they can cause amnesia. Then they cause idiosyncratic reactions also, so excitation in some patients. Then fourth, they are absolutely contraindicated in acute intermittent porphyria because they increase porphyrin synthesis. How? Because they induce the enzyme porphyrin delta ALA synthetase, right? Fifth point, very important, at high doses they cause poisoning, right? Poisoning कैसे treat होती है? Let us write it here. Poisoning of barbiturates. Now, how do we treat the poisoning of barbiturates? The first thing is gastric lavage. So we reduce the absorption of any barbiturate that is lying in the stomach. Second is they are treated by forced alkaline diuresis, right? And the third thing that we can do is hemodialysis. We can just increase the excretion of barbiturates from the urine. So this is the detail about the barbiturates. Okay, now next we go to benzodiazepines. So benzodiazepines के हमने देखा कि they are GABA facilitatory action. Now these drugs, they are used as anxiolytics. They are used as anticonvulsants, and they are also used as central muscle relaxants, right? So these are the barbiturates have got a lot of use. They are very good drugs and very commonly used. So now the multiple central muscle relaxants may be normally used diazepam. Then anti-anxiety may we have diazepam, lorazepam, alprazolam, which is very commonly used, and chlordiazepoxide. In muscle relaxants also chlordiazepoxide is used. In anticonvulsants we have diazepam, we have clonazepam, we have clobazam, we have lorazepam. So these are the various drugs. Then in hypnotic uses, that is for sleep. We have many drugs like diazepam is there, flurazepam, nitrazepam, temazepam, triazolam, quazepam, and midazolam. So these are the various drugs which come under benzodiazepines. Now benzodiazepines are preferred over barbiturates. Why? First of all, they have a safety profile is good, and they have a flat DRC. So, and they have a high therapeutic index. Okay. Second, they cause less hangover and less distortion of sleep architecture, and that is why they are more beneficial in insomnia. Then, in fact, nitrazepam increases the REM sleep. REM sleep is the dream sleep. Then less drug interactions. In fact, very little drug interactions they have. They don't have any. Then less abuse liability, and they do not cause dependence. Then sixth, poisoning can be treated by flumazenil, that is a specific antidote. So we have a specific antidote, right? And seventh, benzodiazepines, they cause analgesia, while barbiturates are known to cause hyperalgesia, right? So these are the differences between benzodiazepine and barbiturates, and that is why they are used very commonly. Then जो short acting होते हैं ना, इसमें short acting ones are used mainly for sleep disorders because they are more they'll not have a cumulative effect. And long acting benzodiazepines, they are mainly used for anxiety and other uses, right? So this is also very important that you don't use long acting one in sleep disorder, otherwise they'll cause hangover the next day and sleep during the day also. Okay, now let us see the adverse effects. What are the adverse effects? Now they are usually much safe, and they can also impair memory and learning. And so there is a drug which is flunitrazepam. This is also called as a date rape drug because it produces amnesia, and so the memory is not there. Then some paranoia or psychiatric disturbances can occur with triazolam. Then there is a drug midazolam that can result in ataxia and blackouts in elderlies, right? And then flurazepam can result in paradoxical insomnia. So you, instead of causing the patient to sleep, it will increase the insomnia, right? Then if we talk about the poisoning, I've already told you, poisoning may be used flumazenil, which is a competitive antagonist, right? So this was about barbiturates and benzodiazepines. Now let us come to the newer drugs. So new drugs, the first drug that we have is zopiclone. Zopiclone, basically it attaches to, again, the GABA benzodiazepine receptor only at a different site. It prolongs stage 3 and 4 and does not affect the REM sleep. Okay, chances of rebound, insomnia, and hangover are less than benzodiazepine and barbiturates. So this drug is used in the insomnia, and also used in patients who are taking benzodiazepine for induction, inducing the sleep. Insomnia में दो तरीके के problem होते हैं. One is induction of sleep. The patient finds it difficult to fall asleep, and the second is maintenance of sleep. That is the sleep break बीच में होती है. ठीक है? Then the second drug we have is zolpidem. Then this binds to the omega-1 subtype of benzodiazepine receptor. It increases the GABA action, right? Now this is very effective in sleep. So hypnotic होती है, amnesic होती है, but it is not anxiety. No effect on anxiety. I'll say no effect on muscle relaxation, and no effect on convulsions. So this is just beneficial in sleep disorder. So it does not distort the sleep architecture, and no hangover also, or rebound insomnia, right? So this is used in the in insomnia. Then the third drug that we have is zaleplon. Now zaleplon also binds to the W1 subtype of benzodiazepine receptor. This also is more effective on the insomnia also. So it reduces the latency, sleep latency. It helps in falling asleep, does not distort the, so more useful in persons who have difficulty in falling asleep. Okay, Then the next drug that we have is the orexin antagonist. Now orexin antagonist के अंदर जो ड्रग आती है वो है suvorexant and lemborexant, and means antagonist, and orex से ये वर्ड आ गया orex, suvorexant and lemborexant. Okay, now orexin is basically a neurotransmitter which maintains wakefulness. So antagonist of orexins will reduce the sleep. Then the fifth category that we have is melatonin agonist. इसमें आती है rameltion. So here melatonin का melt हो गया, receptor agonist rameltion. And the next drug that we have is tacimeltion. So melatonin यहाँ से आ रहा है. Now they are basically, you know that melatonin is secreted from is a hormone of the pineal gland, and this it synchronizes the sleep cycle, the circadian, I'll say not sleep but circadian rhythm, जो हमारा day night की जो cycle है, it is because of the melatonin. So this drug is used to reduce the effect of jet lags. Then in adults, in elderlies, it can be used. Then it can be used in shift workers, जो day night day होती है उनमें कर सकते हैं. Then adverse effects इसके होते हैं that it can precipitate epilepsy, it lowers the seizure threshold, and it can cause psychiatric changes. So these are the effects of melatonin, right? Then other drugs are there like chloral hydrate, glutathione, and meprobamate. Now chloral hydrate का जो active metabolite होता है उसका नाम है trichloroethanol, right? Meprobamate is a metabolite of carisoprodol, which is a CNS relaxant. So they also have a CNS depressant property, but they are rarely used, not very commonly used. Then there is one more drug that is trazodone. Now this trazodone is an antidepressant actually. Trazodone is an antidepressant but can be used in insomnia, short-term insomnia. इसका trazodone का adverse effect है priapism, so it is again not very commonly used drug. So with this we finish the sedatives and hypnotics. Okay, next we move on to the Parkinsonism. The next disease that we are going to talk about in CNS is Parkinsonism. Now Parkinsonism is a neurodegenerative disease. Okay, it comes under the category of neurodegenerative disease, and it is characterized. What are the features of Parkinsonism? It is characterized by rigidity and bradykinesia, dyskinesia, tremors, then mask-like face, and the main feature by which you normally identify a patient is unstable gait. They have difficulty in walking. Now, what is the reason for this? What happens is in the basal ganglia in our brain, there are two types of neurons that are dopamine, and the other one is acetylcholine. Now, these two neurons, they manage the balance of our these two neurotransmitters. They play a major role in the balance of the body. Now, in Parkinsonism, the problem that happens is that there is a decreased nigrostriatal dopaminergic neurons in the basal ganglia, and there is appearance of Lewy bodies that you must have studied in pathology also. So as a result, in Parkinsonism, what happens is there's an increased acetylcholine activity and there's a decrease in the dopamine activity. Now, increased acetylcholine and decreased dopamine activity results in an imbalance, right? And this imbalance causes the features of Parkinsonism that we see. So the treatment is mainly focused on two things. First is it increases, the first mainstay of treatment is to increase the brain dopamine activity, right? And to reduce, the second therapy is to reduce the central cholinergic activity. So these are the two important features. Parkinsonism के ये important mainstay of therapy है to increase brain dopamine and to reduce the central cholinergic activity. Okay, now when we come on these two therapies, to increase the central cholinergic and to decrease the brain dopaminergic, right? These are the two mainstay therapies. So what are the treatment modalities that we have? The first one is by increasing the dopamine precursors. Okay, now dopamine precursors में the first drug that we have is Levodopa, right? Now with Levodopa we also have one more drug that is Carbidopa. And what is Carbidopa? Carbidopa is a dopa decarboxylase inhibitor. Okay, this is Carbidopa is given with Levodopa. Then so this is, I'll say, the first category. The second modality is to inhibit the metabolism of dopamine. right? So drugs which will inhibit the metabolism of dopamine, in this we have MAO-B inhibitors and we have COMT inhibitors. So these are the, because these are the two enzymes which basically metabolize the dopamine. And so MAO-B inhibitors में the drugs that we have is selegiline and rasagiline. And in COMT inhibitors we have entacapone and tolcapone. Okay, so these are the drugs which will inhibit the metabolism of MAO enzymes. Then after that we have drugs which are, I'll say the third category, dopamine agonist, right? So in dopamine agonist we have drugs which are agonist at D2 receptor, and in this the drugs that we have are ergot derivatives, that is bromocriptine and pergolide, and then newer non-ergot agonists are pramipixole and ropinirole, right? Then there are newer drugs also in this, that is rotigotine. Then many other drugs, other miscellaneous, I'll call them as miscellaneous. In this we have apomorphine and we have amantadine. Then there are some new drugs which is istradefylline, right? So these are drugs which will act through miscellaneous mechanism. Coming back to the central anticholinergic, sorry, it was anticholinergic. So central anticholinergics, because actually dopamine decrease हुआ है, so acetylcholine effect has become loud. So central anticholinergics में the drugs which we have are trihexyphenidyl, that is also called as benzhexol, then procyclidine, biperidine, benztropine, orphanadine. These are the drugs. Then we can also have antihistaminics like promethazine and diphenhydramine, right? So these are some other drugs which and central anticholinergic actions जो कि impact लाती हैं in Parkinsonism. So this is the classification and understanding of the drugs. If I try to utilize this space and I'll make you understand that dopamine, let's understand it here, that tyrosine, we know the formation, tyrosine forms dopa and dopa forms dopamine, right? Now this dopamine is, this dopa is converted to dopamine by dopa decarboxylase, and this action is inhibited by carbidopa. So carbidopa is the inhibitor of dopa decarboxylase. Then this dopamine is metabolized by COMT enzymes 2,3-orthomethyl dopamine. So this action is inhibited by entacapone and tolcapone, right? And inhibited this dopamine, then it enters the brain. Now in the brain, dopamine, we want this L-dopa, more of L-dopa to reach the brain. Okay, now it has entered the brain. This is the brain part. Okay, now in the brain, dopamine is here. So here again it gets metabolized by COMT enzymes and by MAO enzymes, 3-orthomethyl dopamine and dopac MAO-B. So COMT के blockers मैंने आपको बताया था, यहाँ पे कौन करता है brain में? Tolcapone. Tolcapone is the only COMT inhibitor which has activity in the brain. MAO-B को कौन inhibit करता है? Selegiline and rasagiline, right? Now dopamine goes and acts on the D2 receptor. Okay, so what are the drugs which act on D2 receptors which are having a positive impact? That is pramipixole, ropinirole, bromocriptine and pergolide, right? So these are the drugs which act on the dopamine receptors. And amantadine basically, it also acts here. It increases the presynaptic release and decreases the reuptake. So it increases the synaptic dopamine levels by decreasing the reuptake. So that is the mechanism of amantadine. Amantadine also acts on in the CNS. So let's go one by one to each drug now. So the first drug that we had seen was levodopa, and this is combined with carbidopa. So carbidopa, it basically what it inhibits the peripheral decarboxylation of L-dopa, right? So increases the L-dopa reaching the brain, right? So peripheral conversion हमें अगर levodopa peripherally release हुई, peripheral conversion अगर हुआ levodopa का, तो क्या होता है? It first of all it results in postural hypertension. So that is a side effect that is seen with dopamine. Then it can also result in this peripheral is because of vasodilatation, D1 receptor. Then by acting on beta 1 and alpha 1, it can cause arrhythmias. Then it can also cause hypertension in high doses. So these peripheral actions can be seen when dopamine is created or is produced in the peripheral region. Now, when you combine with this, so levodopa is combined with this, combination has beneficial effect. This combination, rigidity and bradykinesia respond better than tremors. Okay, so with this it is seen that rigidity and bradykinesia, they respond better than tremors. Other adverse effects, if we talk about adverse effects of this drug, then it can result in the peripheral. अच्छा, peripheral में एक और करता है ये, nausea and vomiting भी करता है by stimulating the CTZ center. Then it is seen that on a long-term use, it produces wearing off, on-off phenomena. So this is because it has got a short half-life. Long half-life, if the drugs which are having long-acting dopamine agonists, they show little on-off phenomena. Then second is abnormal coriform movements, or what you call as dyskinesia, can occur with prolonged high-dose treatment also. And this adverse effects can be treated with amantadine or levotiracetam. Okay, then the next thing, that L-dopa causes hallucinations, vivid dreams and psychosis. So in elderly it can cause these symptoms. So then in that case the drugs can be used are clozapine and quetiapine, right? Then it can cause mydriasis, so it is contraindicated in angle closure glaucoma. Next pyridoxine, if it is given, pyridoxine अगर कोई patient ले रहा है, vitamin complex ले रहा है, then it can reduce the efficacy of levodopa, right? Because pyridoxine is a cofactor of dopa decarboxylase enzyme, so this results in reduced efficacy of L-dopa. Then next है abrupt withdrawal, can precipitate neuroleptic malignant syndrome. Then to be given carefully in patients with peptic ulcer and malignant melanoma, because dopamine or levodopa. Now malignant melanoma में क्यों? Because here it can cause bleeding and here it can cause L-dopa. Levodopa is a precursor of melatonin. Okay, so these are the reasons by which these are the adverse effects of levodopa dopamine therapy, right? There are many questions which can be made on these, so please remember them, very important. Next then we have COMT inhibitors. तो COMT inhibitors में हमारे पास कौन कौन सी दवाइयाँ थी? We have tolcapone, entacapone and opicapone. They inhibit the COMT enzyme and so they help in Parkinsonism. They are always given in combination. इनको अकेले देने से कोई फायदा नहीं है. So they are given in combination with L-dopa plus carbidopa, right? Because when we inhibit the dopa decarboxylase enzyme, the metabolism move towards COMT. So we need to, if we give these drugs, then it will be very beneficial, right? Then tolcapone acts in the brain also, so this has got activity in the brain also. So these are the drugs, and now tolcapone is more potent and longer acting, but it is, इसके साथ एक problem है, but it is hepatotoxic, so this is not used now. Now new drug that has come is opicapone, which is the drug which is preferred, and it is used for treatment of off episodes when there is full-blown Parkinsonism, right? Then the next category drugs that we had was MAO inhibitors. Now MAO inhibitors में हमारे पास जो drugs हैं वो हैं selegiline and rasagiline. And selegiline and rasagiline, they are selective irreversible inhibitors of MAO-B, and at high doses they inhibit MAO-A also and can result in hypertensive crisis, which is seen in cheese reaction and serotonin syndrome. Okay, these drugs, MAO inhibitors, also reduce the disease progression, right? So this is also very important, not just symptom amelioration but also reduction of the disease to progress, to reduce. Then there's a new drug, safinamide. It is a new MAO-B inhibitor. Okay, safinamide is a new MAO-B inhibitor and it is used in combination with L-dopa plus carbidopa. It is not used alone, used always in combination with L-dopa and carbidopa, right? Then coming to the next category of drug that we have, that is dopamine agonist or dopamine agonist, right? Now dopamine agonist में the drugs that we have are those which are D2 receptor agonist. So इसमें जो हमारे पास drugs हैं वो हैं bromocriptine and pergolide. These are ergot derivatives. They are short acting, firstly, and secondly they also cause digital vasospasm that can lead to gangrene also, and can also lead to erythromyalgia. So long-term use of pergolide can also result in cardiac valvular defects. Okay. Then non-ergot derivatives में we have pramipexole and ropinirole, and these are non-ergot derivatives. They do not cause gangrene and they are very long-acting. They are long-acting also. Now ropinirole is also approved for restless leg syndrome. They are the first choice for Parkinsonism now, even earlier than levodopa. Levodopa से भी ज़्यादा preferred drugs हैं ये. Important adverse effect is excessive daytime sleepiness. It is rare also, not very commonly, right? Then these drugs, dopamine agonists, also associated with impulse control disorders like gambling, pathological gambling, hypersexuality. So ropinirole is also used in that. Then there's a new drug which is rotigatin. Now this drug is also a dopamine agonist. It was earlier given with transdermal patch, but now discontinued as there was crystal formation on the patches. Okay, so this is about the dopamine agonist. Now other drugs, miscellaneous. We have amantadine. Now amantadine is actually an antiviral drug. It is used in anti-influenza, right? But it is seen to be useful in Parkinsonism because it increases the synaptic dopamine levels. It causes, क्या करता है ये? It increases the release and reduces the reuptake. So by this it increases the synaptic dopamine level. Plus it is also anticholinergic and also NMDA blocker, right? Now adverse effect of amantadine is very peculiar. It causes livedo reticularis. So this is one side effect of amantadine which is very problematic. It is mainly used for dyskinesia associated with chronic levocarbitherapy. Okay. Then other drug that we have is apomorphine. Now what is apomorphine? Apomorphine is a selective antagonist at adenosine A2A receptor. Now normally what happens is adenosine binds to the receptor, this A2A receptor, and it inhibits the dopamine receptor, right? So sorry, the drug that I'm talking about here is not apomorphine, it is istradifylline. Istradifylline is selective antagonist at adenosine A2A receptor. Adenosine binds to this receptor and inhibits the D2 receptor. So istradifylline, it will actually activate the D2 receptor and antagonizes the effect of adenosine. And it is used in off episodes of Parkinsonism. Then the drug apomorphine, it is given subcutaneously for temporary relief of off period, but it causes very severe nausea. It is an emetogenic drug, so that is why apomorphine is not very popular. Then drugs which inhibit the brain, inhibit the acetylcholine. What are they? I have given you the names also. So these drugs, trihexyphenidyl, benztropine, piperidine, they are used. Then we can also have drugs which are antihistaminergic like promethazine, then diphenhydramine. They are also used. These drugs, but they have their adverse effects. What are they? Urinary retention, constipation, blurred vision, and dry mouth. The 4 side effects of anticholinergic drugs: dry mouth, blurred vision, constipation, and urinary retention. So they are seen with the anticholinergic drugs. Now let's see some other neurodegenerative diseases. Very short, fast देखते हैं. Alzheimer's disease. Now what is Alzheimer's disease? Alzheimer's disease is basically a type of dementia, and that occurs because of formation of amyloid plaques in hippocampus. This is the also neurofibrillary tangles जहाँ present होते हैं. So what happens mainly is there is a loss of acetylcholine. So loss of acetylcholine है तो हम क्या treatment strategy अपनाएंगे? So we increase acetylcholine by giving anticholinesterases. The drugs that we give are donepezil, rivastigmine, galantamine. These are the anticholinesterases which are used. Now these drugs they can be given once daily, like donepezil is given OD and rivastigmine is approved. Then another drug is there that is acetyl L-carnitine. This is also given. This is a structural analog of acetylcholine and it has got antioxidant property. Then we have memantine, which is an NMDA antagonist, which is also approved. And a new drug is there that is aducanumab. This is basically a monoclonal antibody against amyloid A beta, and it is approved for intravenous therapy of Alzheimer's disease. This is the only drug that targets the underlying pathology. So aducanumab is the new drug and the most preferable one. Then there is a disease, Huntington's chorea. Huntington's chorea is a disease when there is a loss of GABA neurons in striatum. So Huntington's chorea is a disease where there is loss of GABAergic neurons in striatum and it leads to increased dopamine overactivity, right, as opposed to Parkinsonism. So in Huntington's chorea we give D2 antagonist. They are found to be effective. Like now we give olanzapine, haloperidol. These drugs are effective in Huntington's chorea. Then there is a drug, tetrabenazine, which is basically dopamine depleter. This is the drug of choice. What? Tetrabenazine is the drug of choice for this Huntington's chorea. Another drug that has come up is deutetrabenazine. This is a vesicular monoamine transporter inhibitor. It can also be used. Reserpine can also be used because it decreases the monoamines. Okay. Then there is a disease called as ALS or amyotrophic lateral sclerosis. Now amyotrophic lateral sclerosis is because of degeneration of neurons in spinal cord, medulla and cortex. And इसमें जो होता है spasticity is seen. The drug of choice is riluzole. This is an NMDA antagonist. So this is the drug which is used in amyotrophic lateral sclerosis. Baclofen is also the drug for symptomatic treatment. And then there is another drug, edaravone, is a free radical scavenger, also recently approved in ALS. Edaravone, baclofen and riluzole. These are the drugs used in ALS. Then there is another disease that is Wilson's disease. Now this is basically hepatic or hepatolenticular degeneration disease due to increased copper accumulation. So इसमें जो drug है वो है हमारे पास वैसे D-penicillamine. D-penicillamine is a chelating agent and it can reduce the copper, but it causes lupus. It causes optic neuritis and it also causes blood dyscrasias. So it cannot be used. The other drug that we use is zinc sulfate and potassium sulfide. These two decrease the intestinal absorption of copper. So these are the drugs which they also sequester excess copper in the body. So they are used and they can be used in pregnancy and in children also. Then there is one more drug in Wilson's disease, that is trientine. This is another copper chelator and less toxicity. So in Wilson's disease, the drugs that we have, D-penicillamine, because of toxicity it is not used. The other drug that we have is zinc sulfate and potassium sulfide, and another drug trientine. So these are some diseases. There's one more left, that is called as multiple sclerosis. One degenerative diseases which is left is multiple sclerosis. ये हमारा अभी बचा है तो इसको भी हम खत्म करते हैं. So multiple sclerosis is a degenerative disease. Basically it is an autoimmune disease, and this autoimmune disease is resulting in demyelination of neurons. Now multiple sclerosis is important because they ask many questions on this. So acute episode of multiple sclerosis, the drug of choice is corticosteroids. So you have to give steroids for that and it hastens the recovery, but the extent of recovery remains unchanged and long-term treatment with steroids gives no benefit. Now first line drugs for multiple sclerosis for relapse prevention. They are interferons. उसके बाद आती है fingolimod. Then another drug which is named as glatiramar, and टेरिफ्लूनोमाइड. देयर आर मेनी ड्रग्स. ठीक है, अब फिंगली मोड वगैरह का देखते हैं. फिंगली मोड, बेसिकली दीज ड्रग्स आर sphingosine 1 phosphate receptor modulators. So sphingosine 1 phosphate receptor modulators, these drugs include Fingley mode, then other drugs are Cyponi mode, then Ponesi mode and Uzani mode. Now these drugs, they activate or they stimulate the sphingosine 1 phosphate receptors, right, and they prevent the egress of lymphocytes from lymph nodes and thus reduce the autoimmune system. Now इसके adverse effects क्या होते हैं? They cause bradycardia and can also result in heart block. So the monitoring of heart is continuously required. Fingley mode is also associated with lymphopenia. They can be given orally, right? So these are the drugs, Fingley mode, which are sphingosine 1 phosphate receptor modulators. Then second category of drugs are fumarates. So in this category, the drugs that we have are dimethyl fumarate and diroximel fumarate, right? Now they activate, इनकी action क्या है? They activate the nuclear factor like 2 pathway, and so they benefit in the autoimmune neuroprotective pathway. These drugs are also given orally. Now one adverse effect with these drugs is progressive multifocal leukoencephalopathy, that is caused by these drugs, progressive multifocal leukoencephalopathy. So used in patients with negative JC virus testing, right? This is seen with the fumarates. Now another thing, Fingley mode is also associated with the varicella zoster infections, because they are playing with immunity, so they can also result in varicella zoster reactions. Then we have monoclonal antibodies. Now monoclonal antibodies में the drugs that we have natalizumab, alemtuzumab. Then another drug is metozentron. Okay, let's take natalizumab and alemtuzumab. Now natalizumab is very effective, but again natalizumab also increases the risk of progressive multifocal leukoencephalopathy, right? And the other drug alemtuzumab, this can also result in increased varicella zoster infection. So if the disease activity continues despite the first line drugs, that is Fingley mode fumarates, then you can give natalizumab, alemtuzumab and other drugs. Then the other drug that we have is metozentron. This is cardiotoxic also. Then another drug is teriflunomide. Another drug is there, that is dalfampridine. This is basically an oral potassium channel blocker, and it is given in patients to improve walking. It can cause seizures. Then we have modafinil, which we have also seen with ADHD. Modafinil is used to improve fatigue in patients with multiple sclerosis, right? Then we have ocrelizumab. This is a CD20 directed monoclonal antibody, and it is approved for relapsing and primary progressive multiple sclerosis. It is used there. Then there's a new drug that is amifampridine. जैसे ऊपर ये देखिए ना dalfampridine, ऐसे ही amifampridine. It is a new potassium channel blocker, and it is approved recently for the oral treatment of Lambert-Eaton myasthenic syndrome. Okay, so this is the therapy of these are the various drugs which we use in multiple sclerosis. Acute episode में we use corticosteroids. First line drugs में we have interferons, beta and Fingley mode, glatiramer and teriflunomide. Then Fingley mode is a sphingosine 1 receptor modulator, but it causes some side effects also. Fumarates, they activate the nuclear factor like 2 pathway, but they cause progressive multifocal leukoencephalopathy. Then natalizumab, alemtuzumab are monoclonal antibodies. Metozentron cardiotoxic होती है. Teriflunomide is liver toxic. Dalfampridine is a drug which it is used in improving the walking. Modafinil is used. Ocrelizumab used. Then amifampridine is now recently approved for treatment of Lambert-Eaton myasthenic syndrome. The next video will have drugs which are acting on epilepsy. So anti-epileptic drugs, antipsychotics, antidepressants, anti-maniac, anti-anxiety, and the opioid receptors also.